Consider that it's minimally invasive, so there's 1 to 2 millimeter incisions in each groin with low risk of complications like infection and wound dehiscence. Patients typically ambulate much faster after the procedure, and their total length of stay in the hospital is much shorter. The operation itself is on average about 45 minutes shorter than a femoral cut down. There are increased risks of bleeding and hematoma formation if the closure devices aren't properly deployed, and there's an increased risk of femoral artery occlusion, pseudoaneurysms at puncture sites. For femoral cut down, this is considered for patients with very calcified arteries, because you have the option for endarterectomy and cleaning out the vessel. If the patient has a history of a bypass graft in that region, if they're morbidly obese, as the body habitus can inhibit the closure devices from properly deploying, they have smaller tortuous vessels, and also if anything happens, you have direct access to the vessel for repair. So the idea of an EVAR started in the mid-1900s, and just to put it into perspective, ultrasound was discovered in the 1940s. The first stent grafts were created in the 1970s, and they were actually made of the same material they used to make parachutes in the military. CT scan was developed in the 1970s, and 3D reconstruction wasn't introduced until 2006. The overall mortality rate from ruptured AAAs decreased by 3.5% per decade between 1954 and 1997, just from advanced imaging and fluoroscopy and advancement in devices. The current grafts on the market today are made of Dacron or PTFE. They have stainless steel, nitinol, or cobalt skeletons, and they adhere to the vessel walls by hooks, barbs, or anchors, and they're fixated either above or below the renal arteries. EVAR is the mainstay for treatment for AAAs currently. It's minimally invasive, so most access sheets that we're using are 15 to 19 French on the outer diameter, and 1 French unit is equal to 0.33 millimeters in diameter. And you can see on the photo kind of the vessel diameter in comparison to the sheet size. It's a shorter length of stay. We use fluoroscopy. You can do it under general or local anesthesia, which is really important with these very sick patients, as they may not be able to tolerate general anesthesia. And the 30-day mortality is significantly lower than open repair. Some disadvantages is these patients have to be very closely followed after the EVAR, so getting them into the office for screening and surveillance can be difficult. You have to worry about the grafts migrating, endoleaks, and more interventions following EVAR. The sac regression rates are varied because in an open repair, you're dissecting out the sac itself. And then there's limitations just simply due to anatomy of the vessels in patients. Currently, these are the 7 devices that are approved by the FDA here in the US. There's many more that are not approved here in the US, but they do exist. So just some highlights of all the devices. There's the Medtronic Endurant. It has one of the lower neck lengths, so it's greater than or equal to 10 millimeters. Or if you're using their Healy Endo Anchor system, you can use it in greater than or equal to 4 millimeters. And it allows for inoperative sizing when you're actually in the case doing it. The Terumo, it has a pretty standard neck length, but it's known for having a wide variety of lengths and sizes to choose from. Endologix has 2 different devices. The AFX2 has a 15 millimeter non-aneurysmal neck. It's actually built from the bottom up, so you're starting at the aortic bifurcation and building proximally. And that allows for, if in the future you have to do an angiogram on these patients, you can do your standard up and over techniques. And then in the Alto, it has the shortest neck length, so it's greater than or equal to 7 millimeters. It's the lowest profile, so the outer diameter is 15 French. And then it uses a polymer that you inject during the case to help seal the graft to the vessel wall, and that decreases radial force and chance for migration later on. Gore has 2. There's the excluder and the excluder conformable. The excluder is pretty standard, and the conformable has variations in the neck lengths as it allows for more angulation and proper deployment. The Cook Zenith Flex, it was actually one of the first devices created back in 1993. It was the first 3-piece stent graft, and the design for the stent graft has stayed consistent even till today. Pretty standard neck size, and it's very useful if you have very tortuous iliac limbs. And the main body has a long length, which if you need to extend upward with a Z-Fen device, you have the ability to do so. The two additional stent grafts that are FDA approved are the Cook Z-Fen. It's the only fenestrated graft currently approved. It's used in patients with juxtarenal AAAs that have a neck length greater than or equal to 4 millimeters. You have 2 fenestrations for your renal arteries and then a scallop for your SMA, and each graft is customized to the patient. And then the Glor Excluder IBE is the only iliac branch device, and it's used with patients that have concurrent iliac aneurysms. So after they undergo their EVAR, you want to bring them in for screening. So CTAs at 1 month, 6 months, and 12 months, and then every year thereafter for stable AAAs. At some point, you want to consider switching them over to ultrasound just to avoid contrast. You want to make sure their blood pressure is under control, they stop smoking. And when you're actually getting these scans, you want to be looking for sac regression or enlargement, migration, and then endo leaks, which is the most common complication of the EVAR device. There's 5 types of endo leaks, type 2 being the most common, and that is when a side branch, such as one of your lumbars or your IMAs, is feeding into the sac, causing it to enlarge, and those are typically treated with coiling. Type 1 is the second most common, and that's when proximally or distally the graft is not attached, and you can either treat with relining or balloon angioplasty. Looking forward, EVAR is kind of the future of treating these AAAs. So the use of branch or fenestrated endografts for all different anatomical sites are being developed and in clinical trials. The thought is being that we may be at some point able to stent from the entire aorta all the way down to the distal bifurcation in iliac and femoral arteries. Ultimately, choice to undergo EVAR is based on the patient's comorbidities and their anatomy, and devices are dependent on the patient's anatomy and surgeon preference. Thank you.